Up next, we're going to have a virtual presentation by Chris Jacobs with the senior author of Thomas Huber from Gainesville, Florida, outcomes of open mesenteric bypass for chronic mesenteric ischemia among elderly patients.
Hi, my name is Chris Jacobs. I'm a second-year vascular fellow from the University of Florida. Thank you for the opportunity to present. Today, we're talking about the outcomes of open mesenteric bypass for chronic mesenteric ischemia among elderly patients. I have no disclosures. Open mesenteric bypass can be technically demanding and is associated with significant morbidity and mortality. Increasingly, there is a greater prevalence of CMI in the elderly. However, little is known about open mesenteric bypass outcomes in this population for those presentations not amenable to endovascular therapy. The purpose is to analyze outcomes of open mesenteric bypass in the elderly population, which are defined as equal or greater to 75 years old, for CMI, and compare this with a cohort of younger patients. This is a single-center retrospective study of a prospectively collected database. All patients who were undergoing an open mesenteric bypass for chronic mesenteric ischemia were evaluated. There were a total of 146 procedures over a 20-year study period. The primary endpoint was 30-day mortality, and secondary endpoints are as follows. What we found is that for the elderly patients, there was a greater prevalence of females. There was increased comorbidity of hypertension, dyslipidemia, coronary artery disease, and congestive heart failure. The admission mode was equivalent for both the young and the elderly, and the EBL self-saver use was equivalent. There was a minor increased use of crystalloid in the younger patients. Conduit use was over 90%, Dacron conduit, no difference amongst the patients. And revascularization to a combined SMA and common hepatic artery target were equivalent amongst the group at 70+%. Interestingly, retrograde bypass configuration was not increased in the elderly, nor was prior mesenteric stenting. What we noted is that length of stay for the elderly was more than a week longer. Any complication and total number of complications were increased from 40 to 80% in the elderly. These comprised cardiac, bleeding, and then renal failure requiring dialysis to be much higher in the elderly population. In-hospital mortality had a trend to be increased in the elderly at 6 versus 15%, while 30-day mortality was non-significantly increased at 5 versus 11%. Interestingly, we found that the 90-day mortality was more than threefold for the elderly at 19% versus 6%. Additionally, discharge status to rehab was higher in the elderly versus the younger population. Reintervention was equivalent. We found that the freedom from all-cause mortality listed here was drastically reduced for the elderly, especially within the first 12 months, as you see the KM curve here, the red being the elderly. Independent predictors of mortality were listed here. The renal failure rate requiring dialysis had a hazard ratio of 9.7. Additional complications and preoperative comorbidities are listed here. Interestingly, elderly alone was not an independent predictor of mortality, while the age increase per year was only a very small contributor of an independent predictor of mortality. Retrograde configuration was not protective. On a multivariate model, we interestingly found that being female sex was greatly increased independent predictor of mortality, while renal failure requiring dialysis was as well. In conclusion, open mesenteric bypass outcomes for CMI in elderly patients are sobering. This reflects a higher comorbidity and physiologic frailty. As vascular care provisions evolves for an aging population, elderly CMI patients that are not endovascular candidates may become an increasingly common presentation, which underscores the importance of defining goals of care preoperatively and implementing any processes to decrease postoperative complications. Thank you very much, and I'll take any questions.
I just have a question there, Chris. For patients with, we said retrograde wasn't a large component. Was there any difference you see with the proximal inflow, such as supraceliac versus infrarenal as inflow? Were you able to determine that?
Sure. Well, first of all, thank you very much to the VESS committee for having me present today. Thank you for letting me be virtual. I got sick last month and I was ECMO and coded, and I got out of the hospital for 3 weeks, and I'm back operating again, and VESS contributed to my recovery, and I appreciate that. To answer your question, there was a mild difference in increase aortic complexity with the supraceliac clamp versus infrarenal in both groups. It was not significantly different for the elderly or for the younger cohort. Of note, as I mentioned in the independent and the multivariate analysis, just being elderly alone did not contribute to worse outcomes. It was the comorbidity profile of the elderly that increased their perioperative morbidity. For those elderly patients that had less comorbidities, for example, in some of the younger patients, especially for the elderly male patients, they actually did comparable to the younger cohort. So I think that that's very important. Sure, patients with the supraceliac clamp versus infrarenal have a little bit worse profile of postoperative outcomes just because of renal malperfusion and more of a physiologic hit. But I think the very interesting take point from this is that elderly patients overall are more physiologically frail, but if you can select out an appropriate patient for CMI, you can get them through the hospital stay with reasonable outcomes.
Great.
Yeah, Mark Hunter from Boston. I agree that age can be a surrogate for frailty, but did you look at any nutritional labs? Because I found with my chronic mesenteric patients, it's really all about their pre-albumin and their albumin levels and the other nutritional labs that make a difference in whether they're going to do well. And the patients that are really on the low end are the ones that tend to have trouble getting out of the hospital.
Yeah, I'm glad you asked that. So actually last year at VESS, I presented the psoas muscle index for patients with CMI and then EVA conversions. And for those patients with worsened psoas muscle index, regardless of albumin or pre-albumin levels, we actually found that they did worse. For our patients that had, pre-albumin or albumin levels, we found that it wasn't great. And part of that may be the sample size. If I had, a couple thousand patients, it made it easier to tell that. But I was not able to delineate that because we did look at that.
Misty Humphreys from UC Davis, and I didn't get up to ask a question. I got up to thank you. I got up to thank you for presenting and also for being a person who's come to the VESS several times. I know this is one of your favorite meetings. I'm sorry that you couldn't come this year, and we really hope that we do get to see you live next year. So I think you are an incredible person.
Great. Thank you.